Good afternoon. My name is Tricia Livingston. I'm the Kaizen Director here at the Kaizen Promotion Office, and I'm pleased to report out on our mistake-proofing project that is on the safe administration of insulin. We will be reporting to a TAC time of 28 minutes, and you will hear from each of the team members on the various standard report-out documents. This is a photo of our team. Our team was comprised of 2 members from 3S Health, Shared Services Saskatchewan, and 2 members from the Ministry of Health. So from left to right, we have Kendall Arndt from 3S, Pam Buzash from the Ministry, myself, and Mark Anderson from 3S as well. This is our project form. Our sponsors were with the Regina Capel Health Region, Val Davies and Lori Garchinsky. Our process owner, who was just fabulous, was Teresa Russell. She's unfortunately on vacation, or she'd be here. I was the team lead, Pam was the sub-team lead. We had KPO support from Julie Johnson, and content experts from the pharmacy at our QHR. Our team members were comprised of the 4 of us here, plus some cardiac registered nurses and a nurse educator on the cardiac care unit where our project took place, and also a representative from pharmacy. Pam's going to dive into the PQA data a little bit more, but I will tell you there, when we first looked at the data for the region, we found that about 6% of the medication errors that are recorded in the region are related to insulin administration. We're also going to show you our current value stream map. There's a high-level process flow map there, and someone else will speak in detail to all the different steps that we were looking at. So to tell you a bit about our current situation, there are many different strengths and brands of insulin that both look alike and sound alike, which increase the risk for the wrong dose, strength, or type of drug to be administered. And we were quite shocked and surprised to learn all the different names and just how common they are. So there's Humulin, Humalog, Novolin, Novolog, Humulin R, Humulin L, Humulin N, and so it just kind of goes on and on and on, and they look alike, sound alike, and all have can be fast-acting, short-acting, and so there's a real opportunity for error, as you can see. We also found on the unit that there were no standard processes for the storage of the product, or removal of expired product, or the removal of patient-specific meds that were no longer needed. Every unit in the hospital uses insulin products. The volume varies. Insulin is identified as one of the top 5 high-risk medications by the Institute for Safe Medication Practices. The risk of harm is very significant. Typical reactions include hypoglycemia, which can lead to sudden and severe reactions, including death. So our theme was to mistake-proof the administration of insulin so that we were supporting staff to provide the appropriate product, the right strength and dose to the right patient at the right time, every time. Our target was 0 defects in the subcutaneous administration of insulin, which just means through a needle. Our defect was identified as a failure to complete an independent double check, which is an evidence-based best practice for insulin administration and was not standard policy in this unit nor in the region. This next form is just a time observation form that shows you how we're collecting information that we use to form our current value stream map. You'll see this is from October, so pre-tour. We're still trying to figure out what are the steps in the process. We just wanted to show you that we collected that information through observation. The next picture is a blueprint of the cardiac care unit where we were working at the Regina General Hospital. In the center there, that circle is the medication prep area where we mostly focused, and around the edges are the patient rooms. This is a spaghetti diagram of how the process occurs, so you'll see there's a little bit of walking back and forth between the med prep area and the patient's room. We primarily focused on where the meds were kept and where the medication was prepped. This is our current value stream map. Again, it was created through observations. The process that we focused on was the RN checks initially the medication administration record for the type of dose, goes to the place where the syringe and insulin are stored, draws up the insulin. The RN performs a self-check, and some were just on their own performing a double check as well. Then the RN goes to the patient's room, identifies the patient, injects the insulin, and documents on the mark. Overall, the process took about 3 minutes and 53 seconds. We found the value-added time to be about 90%. There were a couple of short walks in there. Our focus was not primarily on reducing the time, of course, but focusing on the defect. And you'll see on top our red Kaizen bursts are the opportunities we identified for improvement. Just like all of the other teams, we're also presenting our mistake-proofing assignment form that we completed as part of our planning for our North American tour that we did in November. On the top there just identifies the situation, which I've already told you about. We looked at the contributing factors, so we found the product identification wasn't clear, multiple products were stored together, no standard process for removing expired product. It was difficult to see in the med prep area, the lighting was poor, the syringes were very difficult to see because the graduations on them were very small, and staff were interrupted many times during medication prep. Our current mistake-proofing level was set at 3, where we felt most nurses consistently were doing a self-check at least. And our defect rate was 80% based on the fact, on the observations that we did. And in the future, we will be measuring the defect through an audit, and we'll give you the audit results later in the presentation. Other things on this form were just to help us identify what our targeted improvements were going to be, how we were going to engage our staff in those ideas, how we would test them, and how we would communicate our changes. So post-Kaizen, we have increased the mistake-proofing level to 4. Our defect rate has been reduced to 5.8%, which is a 93% improvement. And next, I'll call up Pamela.
Good afternoon, everybody. As Trish said, I'm Pamela Buzash with the provincial, or the Kaizen Promotion Office here at the Ministry, Workflow Coordinator. I'm going to talk a little bit about our PQA data that we collected. We started out with some data from the province itself, and this is critical incidence data for the province of Saskatchewan. So in total, in a year period, we had 11 critical incidences around the admission of insulin and 2 deaths in this province. The incidents revolved around things like insulin overdose, incorrect dosing, the wrong type of insulin, the wrong patient given insulin. The outcomes from, you can see through the province were that there were 2 deaths and 11 people harmed. Within the Regina Propel Health region, there have been reported 108 out of 1,857 incident reports involving insulin. 6% were insulin related. And there are multiple examples of the types of incidents. Most of them are is the wrong type of insulin given to a patient and the wrong dose given. It covers off a lot of them. It's that the patient, or it's in fact some of them involve giving patients that are not on insulin the insulin. Wrong dose given was prescribed Humulin N, but was given Novolin, and it's not being prescribed, noted onto the MAR. Within the Regina Propel Health region, also the types of insulin administration medical errors, transcription errors, missed or delayed doses, and of course the wrong drug at 76% on this one. And then we moved on to the CCU, and we did some statistics there for their own unit. Within an 18-month period, the insulin usage was 71 vials were distributed to the unit. And then we carried on with the staff, and we did a staff survey to see what they thought they were doing wrong, or the incidents that they would report. And as you can see, mostly they were reporting that they were coming up with the wrong dose, or they were pulling the wrong type of insulin when administering it, or missing a dose was the next highest one. They had, they registered near misses where the patient was not harmed by the action, but there were 9 on our chart reported. And they didn't necessarily affect the hospitalization of the patient. One for sure required treatment by being given the raw insulin. And this is our Sacred Food Target Progress Report. We are reporting on our percentage of double checks, as Trish said, done by the staff. So our baseline was 80%, the target is 0, and the readings were at 5%. The 5S we did on the unit, which involved the fridge, which you'll get to see in a little while, was at a 4 and a target of 5, and it is now at a 5 and being sustained.
Hi, my name is Mark Anderson. I'm with 3S Health. I'm just going to walk you through some of the improvement ideas we had and some of the things we did to try to get a handle on this mistake-proofing situation. So just some communications first. We did put up our project on the wall for folks to see so that they weren't too nervous about us coming. We also, just had our pictures and a bit of a description about each of us and where we were from. This particular slide actually was around one of the improvement initiatives we instituted. We actually changed the syringe that was being used, and I'll show you that in a minute, but this was an ask for them to support us, and this was put up in addition to having the manager ask for their support. We actually surveyed the staff to get their ideas, and we asked them what they thought could be improved that might help them avoid mistakes with giving insulin. Double check was far and away their number one solution that they proposed, and which is why you can see where we focused on that area. But they also had a number of different ideas that they gave us as well. You can see improving storage of the insulin, switching to a different syringe was another option, and improving the actual identification of the individual. The next slide here is just a fishbone diagram we did. When we thought about how could we attack this issue, we looked at it from 6 different angles: equipment, storage, process, environment, people, and product. And we put some ideas down here. We then posted this fishbone diagram up on the staff wall, and we asked them to provide input and provide us with their ideas. So a lot of the ideas did come directly from the staff on the unit. These are our idea summary sheets, and on the left-hand side, before improvement, you can see there's actually, this was on the medication administration record, and in the past, they actually had to line up and handwrite this on the form with the blood glucose level on the left and then the dosage on the right. And you can see if you didn't write it exactly straight across, the dosing can become misaligned and you can misinterpret actually what the dosage should be. Our idea was to create a stamp that ensured that there was clean lines and actual transparency across. So that was one idea we had. The next idea sheet was around lighting. You can see there was poor lighting in the med prep area, so that was an idea to improve the lighting. The next idea here is about interruptions. There were multiple interruptions during med prep and med administration, and so what could we do we thought we could put in a stop sign and don't interrupt, much like one of the other groups had suggested. This next idea is the double check. So you can see they were doing a self-check, and you can see them doing a self-check of whether or not the insulin was the right dose and the right type. But we had an idea that came from the staff around double check. This next one talks a little bit about the syringe, and previously they were using a 100-unit syringe, and so if you were drawing up something like 2 units or 3 units, it was very difficult to see given the units of measure. We switched to a smaller unit syringe, which was a 50 unit and made it much easier to see. And in fact, there's a 30 unit syringe, which we've suggested in our newspaper to go to. The added bonus was the total cost of these syringes was about 40% of the 100 unit syringe, so there's a cost saving component with it as well, which is great. This was another idea. Currently, they're drawing up the insulin from a vial. There are these pen fills that could be done with the pharmacy. That's per patient. This was one that we didn't end up pursuing. The next one is around lighting and magnification. Can you make it easier to see, how many units you've got in it? This next piece here was actually a check with the patient. So there wasn't always a check going on with the patient to understand, do you take insulin? Do you take this type? Are you diabetic? So that was something we thought we could implement. This sheet here is our standard worksheet, and it just really reinforces the use of the different syringe. And you can see they're saying for doses under 50 units, use the smaller 50 unit syringe, and that happens in most cases. It's under 50 units. But the last piece here is also this double check. So there's a standard process around what do you do for a double check, and there's actually a sign off on the form to make sure that they've actually signed off. We've also implemented, the last piece here is if during the double check there is an issue that's been noted, you have to correct that, but there's actually a root cause analysis that needs to take place to dig deeper, so that if it is something that's got a bigger cause issue to it, that they dive deeper into it so it doesn't happen again. This is some visuals around the 5S work that we did, and so this is a pre-5S. You can see the insulin containers. There's multiple types in here, different kinds. If you're a nurse looking for a certain type of insulin, obviously it'd be difficult to see, which one is which, and it's not all that obvious. Another pre-5S in a drawer, just strewn in the drawer, not very well organized. This is the fridge where some of the insulin is kept. And you can see, in particular on the right-hand side there's 3 boxes that are all orange caps on the top, and those are all different types of insulin. So again, it's easy to see why you get a mistake-prone situation with the type of insulin you might be giving. Another pre-5S, just things strewn in there. So what we did was we did a 5S in the fridge, and you can see we've clearly labeled things both on the box and the container as well as in the fridge. What we tried to do was some things called Pullman lettering. So if it's a Humulin versus a Humulog, we've actually highlighted the lin and the logs to just try to differentiate the brand type. Some things we did. There's another 5S picture, much better organized. Some more 5S. This is our 5S summary sheet, where we took our average score beforehand was 4. It was actually a 4 in some cases, although I think we might have been generous there. And we think we've improved it, to a 5 in that particular area. The 5S summary, I mentioned the increase, the 12-man lettering. We did color code by the type of insulin. We included a par level on the label, and in fact we were able to push some of those vials back to the pharmacy because they were not unnecessary. There's too much. We established an audit process in that case. The next picture is just a picture of our different syringe, and you can see the different unit measures. Here's our stamp, and this is DEMAR, and you can see this was actually our first attempt at the stamp, and it was too small, so the unit actually asked us to produce a new one, which we did. And here's the new one that is much larger, easier to use, and you can see lines up the sliding scale much more easily. And the last one I'm going to show you is our Do Not Interrupt sign that we put in the med prep area to ensure that folks don't get interrupted during the preparation of their meds.
Thanks, Mark. I'm Ken Millard with 3S Health. And as you can see, this is our future state map, and if you're paying close attention, it looks a lot like our current state map, with the addition of the double check step and the process Mark described around catching any errors and the documentation and root cause analysis of any errors. So we did add about 20 seconds to the whole process, and it increased our value add time by about 1% on the whole project. This shows pre and post Kaizen. Double check defect before was about 80%, and then it was improved to 5% post Kaizen. Our staff satisfaction with the 4 improvement initiatives that we did was about 96% on average, and you can see there was a good result for each one of those particular initiatives. The newspaper forum, we used this as a record of items that we needed to continue to do that we didn't have a chance to do through the improvement work that we did. And there's the lighting in the medication room was something that we're still working on, and the magnification piece. We needed to sustain the results through our 30, 60, 90-day audits. We'd like to train the staff, and so that work is underway and is looking to be completed by April. We needed to create a standard physician pre-printed order, as well as a blood glucose monitoring record form that needs to be filled in properly, so some work needs to happen on that piece as well. And finally, the ability to see the units in the syringe, and that's continuing to work. And some of that work is going to continue through PDSA cycles into the future. So in summary, we had a great team, and the work was easy when you have process owners that are so committed to safety and improving the culture within the organization, so that was wonderful. We found it difficult to observe and define our defect, given that on our particular unit there weren't any serious incidents with respect to insulin administration while we were there. So that's kind of where we landed on the double check piece, and we measured that for our project. Go see, go do it, being on the Gamba, seeing the work in action, and we were just really impressed with our team that they just grabbed a hold of these items that they had to do and moved them forward so quickly. It was interesting, the scope was so narrow, at least that's what we thought at the beginning, but there were so many improvement opportunities that came out as a result of the work we did, and so that was something we found interesting as well. And then finally, just to continue to communicate with staff, because that's where all our great ideas came from. So in summary, we just wanted to thank Teresa Russell, the unit manager at CCU at the General Hospital. She was fantastic and really set this kind of the tone and the stage for our group, and it was great working with her and her team. Lucia Parsons and Shelley Gebrandt, our nurse educators, Leanne Yeager, Kelly Babcock, and Lindsay Stovall from the pharmacy, as well as all the staff and all the patients at the CCU at the Regina General Hospital. Of course, our KPO support and Julie Johnson, and I just want to say thanks to my team, especially Trish and Pam for stepping up to do the lead and keeping Mark in line most of the time. Thank you.
There's a picture of you with the crowd test. We're just going to take a quick about 15